Okay. So I'm Alyson. I'm a nurse practitioner, and my role is predominantly the senior clinician for the intake and assessment stream for the Wellness and Recovery Centre and also the inpatient unit. And Dr. Beth Shelton's role is the senior clinician for the treatment stream of the Wellness and Recovery Centre. The Wellness and Recovery Centre was developed in about in April 2011. We undertook a review in about 2010 of the whole eating disorder program, and within that a number of gaps were identified, particularly around having inconsistent treatment and assessment, inexperienced staff, lack of evidence-based treatment, multiple entry points, and particularly limited treatment for the adult population. The Wellness and Recovery...
There's a car that's actually in the way of the construction. It's Zoo 175. If anyone owns it, can they move it, please? No? Okay. Thanks, sorry. I'm filming.
That's better. The Wellness and Recovery Centre is a specialist assessment and treatment service for the whole of life. It's a continuum of care-based treatment, predominantly based on need. It incorporates the Butterfly Day program, which is for 12 to 25-year-olds, the inpatient unit, which is the adolescents under stepping stones, and the adults are based on our general medical unit. And we only have 2 beds for the whole of the southern region. We also have a specialist outpatient treatment, which is predominantly a CBT focused approach. We have up to 45 clients in treatment at any one time. We also have an intake team and assess up to 5 new assessments a week. We also do multiple sort of consultation liaison role. We're a multidisciplinary team, predominantly nurses, mental health clinicians such as psychologists. We did have a social worker, family therapists, dietitians, psychiatrists, trainee registrars. We're also quite incorporated with research at the moment and have 3 research projects being undertaken across our outpatient program and day program. And we do a lot of shared care with our area mental health team, GPs and private treating teams. Yeah. On to Beth.
All right. Good morning, everyone. My role at WRC is very much in adult outpatient, whereas Alyson goes across sort of inpatient and outpatient aspects. And what we're going to do is I'm going to sort of talk really about what we're doing in the adult outpatient component with adults and their families. And then Alyson's going to describe the one sort of innovation we've done in this area, this particular sort of little program called Family Meal Support Program. And Alyson's going to describe that in detail and then just say a little bit also about the inpatient component. So we're really aware that we ourselves don't cover Butterfly, so we'll mention what they do, but we really aren't able to represent that with any kind of degree of authority or depth. So we can tell you about it, but not much really about the thinking behind it and things like that. So I guess this is kind of picking up what Claire was saying. There's not a lot of clear evidence, like as in outcomes for clients around family involvement or not, but there's a fairly persuasive kind of social context for the necessity of involving consumers and carers. And I think the Janet Treasure work is very persuasive in terms of its analysis of how families can be maintaining of an eating disorder and a powerful resource for recovery. So that works really strong. And the Cynthia Bulick work around involving couples in the treatment has got some outcome evidence too, that they're getting some really good outcomes for people with even long-term anorexia nervosa by working within a couples format. Which is really interesting. So I feel like they're the kind of signposts for us in terms of, the thinking that we need to do at the moment. I think that in our service we would regard our involvement with families as very much an area of development, something that we're talking about, that, so we're not like here saying today we've got this perfect or anything like that. We're here to say that we kind of are thinking about it and and it's a hot topic, I suppose, in clinical meetings, you know, about, especially we're getting a lot of clients who are sort of just 18, 19, 20, 21, and I personally, you know, I think we all feel very interested in that group at the moment, and perhaps it's an interesting group to talk about in this respect, because there's no, you have to take it one by one, you have to take it case by case, and as is in this quote, there is this abrupt shift in not only in the treatment system. I know I'm telling you things you know here, you know, between CAMS and adult, and you know all of the things that go with that, and even also how the inpatient system works for young people and older people. Just there's a lot going on when somebody turns 18. Also, they often feel like they've become an adult, so now they have complete right to make treatment decisions, which can be very worrying if the person's quite unwell at that point as well, which is often the case with the clients that we get. And the other thing is that I think as we move really strongly to FBT in paediatric and youth treatment, and then we have a kind of what do we do in adults. There's a number of treatment models. The one that we base on is CBTE, but all of the adult treatment models take a locus of change resides in the individual approach, right? Whereas the FBT work takes a locus of change is in the family approach. So how weird that when you turn 18, the whole theory of change around what's going to happen for you changes, and the treatment context changes, all the personnel around you change, so which making this issue of transition just, you know, really difficult. And so in our clinical meetings, what we often find is these cases come, well, they come all the time, and often the people are quite unwell, because if they're coming straight from, you know, the peds ward, maybe they're bouncing in and out of the peds ward, or perhaps in our case some of them have been through butterfly or are continuing to go through butterfly as well, still quite unwell, and saying, what should we do with this person? Is this person, in our case, what we'd be balancing is these are the sort of three things we'll be thinking about. Is this person someone for whom we go with a cognitive behavioural, immediate sort of, you know, individual empowerment, my way change, with there's an option within that model, which I'll just talk about, which more you probably all know, where significant others can be involved, but it's in quite a kind of reasonably limited kind of way. The sessions are all with the young person themselves or with the adult themselves. Significant others are only enlisted sort of insofar as they can be very functional and very practical about actually getting the person to make change, or if they actually are obstructing change, you know, unwittingly, and so to help that kind of process, so it's very pragmatic. And the suggestion in the manual is like 3 sessions, which are just little add-ons to the individual session, so again, still very much the locus of change. Or do we take a sort of family-based treatment for young adult approach, which really is a completely different approach where all the appointments would be attended by both the person and their family, and it would be taking, you know, the FBT model, so that the person, you know, there's an idea, I suppose, that the person will be assenting to it more because they're an adult, and I'm really talking about now between 18 and 21-ish sort of area. We don't really have enough research evidence yet to show which is, you know, which way to go with which people, but that's what we're tossing up in clinical meetings, and that is a whole lot of factors, isn't it, around what the family's like, what the young person's like, you know, where they live, how close they are to the family, our understanding of how mature they are. You know, there's a whole lot of factors that I feel that we're needing to look at. So the family meal support program there is actually our way of kind of having a formal adjunct to the cognitive behavioural therapy. So you know what I just said about how, like in that paradigm, it's like there are 3 sessions that you do. We've got a 3 to 4 session sort of intervention which specifically links into that. It's a slightly formalised way of doing that, if that makes sense. So just to say, CBT, as you all know, is primarily a one-to-one, individual locus of change sort of thing. As I just said, significant others are only really are seen in that if the person themselves want it, so it's very much to do with the autonomy and focus of the young person themselves, or I say young person, but we have adults, you know, right up to older. If the significant others can help people to make changes, or if others are making it difficult inadvertently for the person to change, or if there's secrecy around the eating disorder, which is helping to maintain the eating disorder. So, for example, I'm thinking of actually an older client now, somebody she was actually like in her 40s, and she'd never told her family that she'd actually been suffering from, a lot of restriction and binge purge behaviours from when she was a teenager. But the whole family sort of knew, because they could feel it in the house, and they kind of knew that Mum rushed off to, the toilet after meals, and that they knew, but it wasn't acknowledged. And, there was a moment in treatment where it was really important for that client to say, look, I really need my husband and my family, which are teenage kids, to come in, and I need to tell them. And, of course, when that happens, then that's a big moment in the family. And also there's more accountability around change, because if you've told everyone. So that's the idea around sometimes the secrecy can maintain the behaviour, whereas when the person opens up and says to the family, this is happening, obviously the family are then going to be, well, Mum, what are you doing rushing off to do that behaviour? And so that can be a powerful thing. So potential sort of conflicts to involving the family, I guess, within that model would be sometimes the client themselves needs to individuate from the family. So, for example, Alyson assessed someone a couple of weeks ago in which there was Mum there and a young man, and Mum just spoke for the young man the entire time, so the young man never actually answered any questions in a sort of 1.5 hour assessment. And that would be, I guess, telling us, this might be a difficult thing. If we want to have a kind of meaningful relationship with the young man, we might need to go gently with how much we're involving Mum at the beginning. You could do it a number of ways, but sort of, possibly he needs to find his own voice. He needs to find a way of expressing himself in the treatment, and so we might make the decision that family involvement might come a bit later. It still might be really important, but might come later. And certainly, I suppose we've also seen the situations where family are highly critical of the person with the eating disorder, and absolutely understandably, because of all the things Claire's been talking about with carer burden and not understanding how these behaviours are continuing in the face of it being, seeming so crazy. So we would also be looking, obviously, at psycho-ed when we need to, at psych-ed, to help people understand what's going on and to reduce criticism. But in that situation, if the family are really, really persistent with really negative feedback to the person, we might try and limit that influence as well. Just another aspect of family involvement, we would also see there to be a sort of risk management component to that as well. So, in terms of if someone's refusing to engage in treatment, or they're refusing to go to their GP and all of those sorts of things, having a relationship with the family is going to obviously be really helpful in those instances. So when someone's very unwell and they're an adult, if we are able to talk to their family, it just makes everything so much easier in being able to manage situations where that person needs to go to hospital or they're refusing things or they're unwell. So, So I think Alyson will go on and tell you more about family meal support and how that works. I suppose I'd just like to leave you with the kind of dilemma I feel like it is at the moment. But, like one client, her name's Tegan, she had hassles with the family. She was a triplet, so there were interpersonal, things in the family. She felt sort of a bit ignored and really passive, and the other triplets were really, full of energy and stuff. And I think perhaps a lot of needs hadn't been met for her, and she was very restrictive in her eating and found it very difficult to sort of build up eating. But she did it herself, and actually in that instance it seemed really good that she did do it herself, because it was about sort of her needing to do it, and she was capable. She had, she was smart, she had resources, she had a lot of strengths. And actually in her instance we didn't involve the family, only in a most distant way. And I think that when it came around to it, she did sort of look at the interpersonal issues herself, and that was a key moment in it. But she ended up going, I did it, and in the instance of her life that was really good. Whereas another person at the moment that we're working with, she's just come out of inpatient, and I think everyone in the team felt that she just cannot change her eating herself. She's the same age as Tandra was, and there are problems in the family, and that there has been even some difficulty with family violence in the past, and we all know that's a difficulty. But in the end we made the decision with this other client, because no one, including her, felt like she could do it herself, to involve her family and take a more of an FBT for young adults kind of approach. And that's with the knowledge of risk, with the knowledge of the difficulties and everything, but saying, no, we think overall in the balance of factors it's worth trying this, because the person's turning 18, and because once they're 22 or 24 or 26, that's never going to happen. You just see what I mean? Like, there's a kind of urgency around it. So I suppose I'm just saying those two cases to characterise the kind of thinking I think that's going on in the team at the moment. Okay. Thank you. Oh, I didn't do butterfly. I didn't do butterfly.
Yeah, go on.
Okay, so I'm just going to quickly talk about what Butterfly do. As I said, I'm not going to represent it in any depth. So there's one family therapist at Butterfly, and just given the time fraction the person works, that person's able to see sort of 4 families at any given time. So Butterfly have a group program, as you probably are aware, and that has numbers of different kinds of focuses for the young person. What will happen is that the key worker, each person in Butterfly has a key worker, and that key worker will say, look, I think this person's family really need to be involved more intensively, and they'll refer that person to the family therapist, and then those families will come outside the Butterfly hours and sort of do some work together. If the client is over 18 years, they have to get consent from the client themselves for that process to happen. And I think the focus of it is to, again, practically focus on recovery and what the family can do and know and understand about the eating disorder, rather than family therapy per se, rather than like dealing with issues in the family in the broader sense. It's inclusive of all the family members, and it's kind of also aware that there's a possibility when you set up a new treatment intervention in any situation that you kind of split from other aspects of it. So there's a kind of view. This is one view, this is another view, this is another view. They all kind of sit together, kind of thing. And the overall goal is open communication between the person and their family and the treatment team, and obviously the support that the person needs to make the changes that they need to make.
Okay, so within the outpatient eating disorder program, we set up about 12 months ago a family meal support pilot program that functions really as an adjunct to the core CBT treatment. It's a skills-based program that involves families eating a meal where their family members learn practical strategies to support through the process. It consists of 3 sessions, predominantly 90 minutes each, and it was facilitated by our family therapist and dietitian, and was very much about practical, experimental, how to engage the family in that actual meal session. There are 3 sessions. 2 sessions are held within the first week, and the final session is held a month later. The impetus for the program was really about recognising families as a major resource in eating disorder recovery, and irrespective of age. Certainly we found that our clients really acknowledged that it would be helpful to engage their families, but often were quite ambivalent about the implications. Similarly, families really expressed needing to really understand the eating disorder to support their family members at home, and a lot of the time they were quite frustrated and felt quite disempowered as family members. How can I support my daughter or son? All of our clients are over the age of 18 in the outpatient program, and it was really an opportunity to identify the importance of families and inviting them into the sessions. Many of the families attending the sessions would include siblings, husbands, children. Could it be a neighbour? It could be a close friend. So someone who was really involved with the client. In terms of the aims of the family meal support therapy, it was really about recognising families, how they can support the individuals in the recovery. It was about normalising family eating patterns, improving physical and emotional recovery, increasing the confidence of the family members around food selection and preparation, reframing the meal times as a positive experience, and encouraging empathy and respect. It really focused on building practical skills in order to increase the confidence at meal times, which included coaching the family, providing encouragement, role modelling, and externalising from the eating disorder. So very much based on the family meal support program for the adolescents, and we just restructured it into a 3-session approach. probably covered this. So it was really about drawing on increasing the confidence around food and eating, supporting the family environment to generate the change rather than leaving it to the individual. A lot of the time in the CBT treatment, it's very much individualised with the family, but then when they go home, they'll report that the parents may be quite blaming, or they might have arguments about particular foods or using particular utensils, or not eating with the family, isolating in their bedroom. So it was really about setting boundaries about how to complete a meal, particularly around the pace of eating, the choice of foods, remaining seated and obviously not using bathrooms prior and after meals. And also, I guess, around the family having that supportive, encouraging role. So as mentioned, there are 3 sessions. The first session is a pre-meal session, and it's aimed to enhance the understanding about family interactions, particularly around meals. It's about providing an insight into the family patterns. A discussion is held with the family members and the patient, and they really identify goals and barriers together around what's important, what do they want to change in the session, providing psychoeducation and strategies for support. The meal session involves the family members eating a meal together, and normally what happens is the family decide on that meal and they bring the meal into the session. And during the meal session, a client's family member may be asked to increase their pace or slow their pace, and it's very much about role modelling and normalising. The final session is really about an opportunity for all the family members to reflect on how things have gone over the month. So they will then go home, continue with the goals, and then come back and review what difficulties might have been or whether any of the challenges were able to be met. And it could include going out for a meal together, going out to a cafe, having a snack together. In terms of the evaluation, there are 2 forms of outcome measures that we've used. The first was a program-specific evaluation that was developed by the team. It looked at key major areas: support during the meals, communication, normalisation of eating patterns, supporting change, and using meals as a positive experience. The second outcome we used was the Scott Miller tool, and this really provides information about the therapeutic alliance and the family's experience of the program itself. I guess, just to say in summary, this is really the early stages of developing the program. It's really about, we see it as a potential for the families to work towards decreasing some of the stress around food and meal times, and it's really about an overall support system for the families, used as an adjunct to the individual therapy based. Normally, in terms of who would be identified for the program, it normally gets discussed in our clinical meetings with the dietitian, with the family therapist, with the key support clinician, with the psychiatrist, in terms of whether this is something that we want to incorporate. And we have the opportunity to run sort of 2 families at any one time. In terms of exclusion, there really isn't a particular exclusion criteria, but it's really about the family members and their difficulties with food and eating and the trauma that may bring on the family. In terms of outcomes so far, certainly short term, it has been found very helpful. However, the application longer term still requires some further evaluation. We've currently got a young girl who undertook the family-based treatment while at home. Went really well, family very supportive, very positive outcomes. She then moved out of home, has since returned home. However, the family are finding it quite difficult to reflect on the previous sessions and how to incorporate that again. So longer term, it's really about, do we continue to repeat it? How many sessions do we do? And what other resources are available for the family? And I'm just aware of the time. Just finally, in terms of the inpatient treatment, as everyone will know, home life is very difficult, and when someone comes into hospital, we remove them from their environment. So things actually can seem quite easy when they're in hospital. They have extensive supports, they have their dietetic support, they have their psychiatrist support, they have psychology sessions, they have nutritional sessions, art therapy. There's always someone available 24/7. However, the difficulty is when they go home, going back into the environment hasn't changed. So really it's about how do we then look at preventing a readmission, how do we look at relapse prevention and ongoing recovery. So what we did is really sort of draw on the learnings from the family-based treatment and meal support therapy, and recognise the importance of the interactions between the family members and the benefits of incorporating them in their discharge planning, and really about complementing the individual work but also with the family. So in terms of the family members, it's very difficult for them to know what to do and how to respond. There's certainly increased level of stress and exacerbation of anxiety. Family members will ring up, and we had one family where the mother said, well, I can't possibly have a home. And the patient, from our view, from the inpatient unit, was ready to be discharged. But from the mum's point of view, well, she's not ready, she's not cured yet, you can't possibly send her home. So what we've done within the inpatient unit, in a number of ways, indirectly and directly, is really look at how we can engage families. So it can be that the family members are invited to the ward rounds. It can be that after the ward rounds that we actually have a phone conversation with the family members after the ward round. It could be that we get the families to come in to assist in the discharge planning. So what are the perceived difficulties of the family members? And this will happen at the point of admission. It's not a week before they're being discharged. These conversations start within the first few days of them coming into hospital. Really looking at role modelling. So one family, we actually ran the family meal support 3 session while they were on the inpatient unit. So to get the family ready, we would certainly get the family, we would do graduated leave, and we would ask the family to incorporate meals. We would get the family to meet with the dietitian and incorporate a meal plan that the family may assist in choosing particular foods or going shopping, and doing a lot of practical work so that the family feel better. I guess it's also about giving resources, printed resources that the family can take away and read, and also looking at what the family needs are. So it might be that we refer the family to their own family therapist, external to our outpatient program, offering some psychoeducational groups, or linking them in with Eating Disorder Victoria, for example, or NEDC, Butterfly. In terms of psychoeducation, it's very much about avoiding behaviours which may enforce the eating disorder. So particularly about commenting on weight and shape during meals, selecting low-fat foods, discussions around feeling full, particularly around discussions around dieting and celebrities, discussions around clothing and fashion. We had one girl that took some leave with her mum, and she went shopping for a swimming costume. So that type of work we would then do with bringing the family members in terms of what is appropriate conversations, how can they best support the family around meal times.